My name is Safura Ramli. I am a professor of family medicine currently in University of Technology Mara. I'm also the deputy director of a research center of excellence with special interest in atherosclerosis and also diabetes and chronic care model, of course.
Excellent. Now tell us about the Empower study, Empower PAR study, because it is, I think, really one of the most important, maybe the only study of implementing the chronic care model in diabetes care in Malaysia. So tell us about the study.
Right, okay. Empower PAR was actually a study funded by the Ministry of Education under the ERGS grant, which is the Exploratory Research Grant Scheme. So our research team, I am the principal investigator for the team. We started the study in 2014 and we completed in 2016. The study basically is a pragmatic randomized control trial in 10 public primary care clinics in Malaysia, the MOH clinics. So we selected 5 clinics for intervention and 5 for control, and they were randomly selected. So it's a randomized control trial. And the intervention for the Empower PAR intervention, it was based on the elements of chronic care model.
So there are 6 elements in the chronic care model, right?
Yes.
And there were 4 compulsory models to be used and 2 which were voluntary. Is that right?
Yes.
Yeah.
There are 6 elements altogether.
Okay.
So the 4 elements we actually converted into the obligatory intervention components. So the 3 components, basically from the 4 elements, we converted into 3 intervention components, we call it. So the first intervention component is called the multidisciplinary chronic disease management team.
Okay.
So this is actually modeled from the delivery system design and healthcare organization. So if we actually study the healthcare organization and delivery system design, then it's about managing type 2 diabetes in a team and having a proactive approach towards management of diabetes. So these 2 actually converted into this, that to be defined as an intervention, a clinic must have a chronic disease management team consisting of at least 5 people in the team.
And the team must have a leader, and the team members should be empowered, right, to enact change within a certain sphere of reference to improve the care for the patient, right? Is that right?
Yes. So the chronic disease management team were actually led by a family medicine specialist, and it has a medical officer in the team, a nurse, and preferably a dietitian or a nutritionist, and also a pharmacist.
Right. Was the nurse a diabetic education specialist nurse, or just a...
Yeah, so if the clinic already has got a diabetes nurse educator, so we will prefer that to be part of the team. And if the clinic doesn't have one, so we actually train. So the way we actually design the intervention, it was using the readily available resources in the clinic. So if the clinic has got a good team already, it's just about enhancing the team. But if the clinic doesn't have any team, then it's about creating a new team and training them.
So when you identified the team, you then had sessions to teach them on the decision support, which was the clinical practice guidelines on diabetes. Is that right?
Yes, because that's another obligatory component. Decision support is about utilizing the guidelines. So yes, and also another component, obligatory component of the Empower PAR intervention is the self-management support, which we designed the red book, which I can see.
And we have a copy of that here.
Yes.
Would you like to just thumb through and just show us what you're talking about?
Yeah. Okay. So this one is given to the patients in the intervention clinic. Each clinic recruited about 100 patients, about 100 to about 120 about 100 patients, because we've got about 400 patients in the intervention arm and other 400 plus in the control arm.
Okay.
So in the intervention arm, all the patients will have this book, but we felt that it wasn't fair just to give it to the patients recruited into the study.
I see.
So actually, each of the clinic receive about 5,000 copies of this
I
booklet.
see.
So patients who were not recruited into the study were also given the booklet
I see.
if they have diabetes.
And this booklet differs from the green book, which is quite standard in Ministry of Health, Ministry of Health books. How does it differ?
Okay.
Yeah.
The green book, if you notice, it's if you flip through as a patient, you're not gonna probably be able to understand it. It's meant as a communication between probably healthcare provider to another one when the patient goes to see a doctor in the hospital, for example. But this book is actually meant for the patient to understand.
see.
We use the concept of global cardiovascular risk.
Okay.
So we have this diagram to show that at the center there is heart attack and stroke, and there are modifiable risk factors there that the patient needs to look into to be empowered to look into them after themselves. And of course there are two non-modifiable risk factors as well, which is age and family history. And we also have got this tick box. So we actually empowered our patients that the more tick box that they have, the more at risk they will be of heart attack and stroke. And as we know, patients with diabetes are very much at risk of heart attack and strokes. And we also have got a page on complications. So, you know,
So if they have existing complications, they mark it out here.
yes.
So that they're aware of this diagnosis. It all sounds very basic, but then it is actually knowledge which many patients don't have in
They
Malaysia.
don't have, yes.
Yeah.
And they don't have a booklet that they can take home and actually study. So many of our patients actually who's been using this booklet, they value it. They carry this booklet everywhere, and they bring it back during the 3 months follow-up, and they also carry it to the hospital appointments when they see their secondary care
And then
specialists.
at the back they have the usual spots for monitoring
Yes.
blood pressure and sugar, and which you fill out at each visit.
Yes, correct. So they have this traffic light system of risk stratification,
Okay.
the treatment targets, and also all the visits to the doctors. Then is we fill it up there. So the nurse, how the multidisciplinary team works is the nurse will actually fill this up.
I see.
And then they will explain to the patient even before the patient sees a doctor.
I see.
So when the patient comes to see the doctor, there is reinforcement
I
of
see.
the targets as well as all the readings which is not achieving target, for example. And then we advise on lifestyle modification afterwards, as well as the pharmacological management and so on.
And when do they see the dietitian and the pharmacist? Is it just one visit a year, or does it depend on how they perform, or what?
Yeah.
Wait up.
Okay. So it depends. So the dietitian is actually there, part of the intervention. So when a patient needs to see a dietitian, then the doctor will get the patient to see the dietitian, preferably in the same sitting that
I
they
see.
come.
So they're not in the Empower part. They weren't automatically everybody saw a dietitian. It wasn't like that.
It wasn't like that. Sorry, at the baseline, everybody get to see.
So everybody,
Yes,
and the
everybody.
pharmacist as well.
Yes,
I
but
see.
subsequent follow-up, because it was a 1-year intervention,
Yeah.
but subsequent follow-up is not necessarily that everybody needs to see a dietitian or pharmacist every 3 months.
Okay. So you haven't told us the results. What did the result? What was the primary endpoint of the study?
Right, okay, so the primary outcome measure
Yeah.
was HbA1c. So the sample size was actually calculated based on HbA1c, on the prevalence of diabetes on HbA1c as primary outcome. So we found that patients who were receiving the Empower Part intervention,
Yeah.
they were at least twice more likely to have their HbA1c under control.
Right. In fact the primary endpoint I think was a reduction in the percentage of a proportion of patients receiving reduction of HbA1c to less than 6.5%, right?
Yes, correct.
And in fact the intervention group there was a reduction of 3.1% or something, and in the non-interventions opposite. The
Yes, it
HbA1c
has gone
actually
up.
went up. Yeah.
Yeah,
Okay.
it has gone up.
But in terms of the acceptance of the staff to your program and the acceptance of the patients to the changes you're trying to make, how did you find that? Was there a lot of resistance, or were they very, very receptive to it?
Oh, that part was it was totally surprising to us that they were very, very receptive. In fact, before we started the Empower Pass study, we did a feasibility study,
I see.
which we already published in the Malaysian Journal of Medicine.
see.
So in that feasibility study, we found that the healthcare providers were willing to be trained.
I see.
They wanted the change, so they welcomed the change. So when we trained them, because the team, we did a workshop. It's called the Chronic Disease Management Workshop, based
see.
on the chronic care model.
Yeah.
So we trained the staff of what chronic care model is all about. And they were very, very enthusiastic. So the challenge is not the resistance from the staff. The challenge is more of the staff, high staff turnover.
There's two more elements of the chronic care model, which is the clinical information system and then community resources and government policies. So how do you see taking this thing forward? Because you've shown very successfully you can do it at a government clinic level. How do you take it forward to use your systems? Have we got, for example, clinical information systems in our government clinics? Or
Yeah, so the other two, the reason why we did not make it obligatory is because the clinical information system, the medical record system, it wasn't standardized among the clinics. Some were using electronic medical record system called the TPC, the Tele Primary Care,
Okay.
and some were actually paper-based.
I see.
So that is something that you can't actually enforce. So that's why we make it optional.
I see.
So those clinic who actually had the TPC actually used the TPC as part of the intervention. So they another thing that they did was actually audit, a clinical audit
Right.
of how they did in terms of their diabetes care
Yeah.
throughout the intervention period.
And that electronic system is very crucial.
It's very crucial.
Yeah.
If we have it, it will be very, very
But our Minister of Health says he wants electronic records in all government hospitals and clinics.
and clinics. We should welcome that.
We should welcome that, yeah. What about community? I mean,
Yeah.
there's the cost spend program before.
Yeah, community resources.
Yeah.
When we did the intervention for Empower Park, cost spend program was not there yet.
see.
So at that time, it was an optional component. So
Yeah.
the clinics who have got a very strong support from their, they call it the health advisor, the clinic health advisor.
Right.
Is the chairman is usually a layman person, a retired government officer or somebody.
Okay.
If they have an active support from this panel, the health advisor clinic, then they became part of the intervention as well.
I see.
Yeah, but cost spend, I must say that it's definitely part of the chronic care model, so
Right.
it should be supported and enhanced.